Pueperium and Breastfeeding. Puerperium refers to the first 6 weeks after childbirth. It is a very critical period where the mother is vulnerable to physical, physiological and psychological changes. First week postpartum. The uterus begins its process of involution immediately after delivery, where it will return to being a pelvic organ by the end of the first week. The cervical os closes. The relaxed lower gastroesophageal sphincter returns to a normal tone within a few days. Damaged pelvic floor heals. Urinary and fecal incontinence have to be managed before healing is completed. After-birth vaginal loss or lochia rubra occurs immediately after birth. Decidua, organized blood clots and fibrin deposits on the inner walls of the uterus passes out of the body in the form of heavy blood flow as part of the healing process. There are 3 stages of lochia: red vaginal loss, brown or red loss, pink loss, and finally a heavy white vaginal discharge, lochia alba. The entire process can take up to 6 weeks before completely stopping. Although a normal process, excessive lochia should be noted as it may suggest postpartum hemorrhage and require immediate evaluation. After 3rd stage of labor, plasma volume decreases due to diuresis, blood loss and excretion of extracellular fluid. Red cell mass increases by approximately 25%, returning to normal within or after 48 hours of childbirth. 2nd to 6th week postpartum. The uterus returns to its pre-pregnancy size by 2 weeks post-delivery. Healing of any injury to the pelvic floor may take longer than 1 week depending on the severity. Risk factors that affect severity of damage include prolonged 2nd stage of labor, instrumental delivery, macrosomia, shoulder dystocia, advanced maternal age, obesity and multiparity. Long-term consequences such as pelvic organ prolapse can be resolved through pelvic floor or Kegel exercises. Risk of incontinence and prolapse can also be reduced with pelvic floor or Kegel exercises during the antenatal period. Ovulation can return early for non-breastfeeding mothers at around 3 weeks. It is also important to discuss about contraception to ensure appropriate spacing out of pregnancies. Mentally, the mother can be overwhelmed during the puerperium. Up to 80% of mothers experience baby blues, which should resolve within 2 weeks. A small percentage will progress to experiencing postpartum depression, anxiety, and even psychosis. If left unchecked, these issues can lead to suicide, which is one of the leading causes of maternal death in developed countries. Other complications. Hematological changes during pregnancy causes hypercoagulation of the blood. There is a high risk of this leading to venous thromboembolism or even pulmonary embolism and death during the puerperium. Pregnant women must be risk stratified after delivery into low, moderate or high risk for venous thromboembolism. This allows for the appropriate use of thromboprophylactic measures. Adequate hydration and early ambulation are advised for all women following delivery. The use of TED stockings or low molecular weight heparin depends on individual risk factors. Puerperal sepsis refers to any source of infection following childbirth. It is a leading cause of postpartum mortality. The sources of these infections may be in the upper or lower reproductive tracts or in distant sites such as the breasts and urinary system. Risk factors for puerperal sepsis include anemia, prolonged rupture of membranes, cesarean section, trauma to the lower genital tract at the time of vaginal delivery, the use of forceps or vacuum to assist delivery, and bacterial colonization of the vagina from Group A and Group B Streptococcus infection. There are 6 basic steps in managing a septic mother according to the Surviving Sepsis Campaign, SSC. Prompt collection of cultures, administration of broad-spectrum antibiotics within 1 hour of presentation, measurement of serum lactate, appropriate fluid resuscitation, monitoring of fluid balance, and a multidisciplinary approach involving the obstetrician, neonatologist, and infectious disease physician is appropriate in severe cases. Breastfeeding. Exclusive breastfeeding is advised for the first 6 months before introducing complementary foods. Correct positioning and latching are fundamental for successful breastfeeding. Incorrect positioning and latching may lead to problems in breastfeeding. Cracked sore nipple. Cracked and sore nipples are caused by incorrect latching of the nipple areola complex by the neonate. Rest the cracked nipple and express milk from that breast until the crack heals. Massage a little expressed breast milk over the cracked nipple to aid in healing. Salt water treatment may also be prescribed. New mothers can seek assistance from lactation-trained nurses to correct latching while breastfeeding. Breast engorgement. Reduced frequency and duration of feeding due to incorrect positioning or latching results in breast engorgement. Frequent and complete emptying of breast is required. Otherwise, express milk to relieve discomfort. Antipyretics are required when breast engorgement is associated with fever. Paracetamol is safe for breastfeeding. Mastitis. Mastitis occurs secondary to obstructed milk drainage caused by blocked ducts, restricted feeding, incorrect positioning, or latching. The most common organism causing mastitis is methicillin-sensitive Staphylococcus aureus. The breast appears tender, red, edematous, and the mother may be febrile. Ensure frequent feeding and complete emptying of the breast to relieve obstructed milk flow with correct positioning, attachment, and expression of milk. Treat pyrexia with hydration, cold compress, and antipyretics. Antibiotics of choice include penicillinase-resistant penicillins such as flucloxacillin or cephalosporins to target the most common organisms. Breast abscess. If not managed promptly and correctly, mastitis can progress to a breast abscess. Depending on severity of the breast abscess, the surgeon can do a fine needle aspiration with antibiotic treatment first, and mothers can still continue breastfeeding. If a condition does not improve, the doctor may then consider incision and drainage through surgery, and breastfeeding is stopped only if the prescribed medications are not suitable for breastfeeding. Insufficient milk. Insufficient milk supply can be managed by hydration, adequate nutrition, and reducing stress factors. Pharmacological interventions include dopamine antagonists. Drugs that reduce breast milk production should be stopped or replaced as appropriate. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynaecology. For more videos like this, head on to the National University of Singapore's website.